Good morning. Happy New Year. I'm delighted to welcome you all to the new academic year, Internal Medicine, Department of Medicine Grand Rounds. As is often the case, we don't have to look beyond our own borders to find just world-class, outstanding speakers, and we're kicking off with two of our own today, with one of the more clever titles I've seen so far. So I always look forward to seeing how people will configure the title for their talks. I'm going to not do either of these speakers justice in terms of my presentation of their background, because we do want to get on to their talks, but I will mention Rob Hoffman is a graduate of University of Wisconsin for both his undergraduate and his medical degrees. He then took residency at the Legacy Health System in Portland and was a chief resident there before coming to the University of Wisconsin again to become clinical assistant professor and now clinical associate professor of medicine. He also serves as the clinical services chief for the Division of Hospital Medicine and is medical director for the inpatient experience for the UW Hospital and Clinics. He's received a number of awards, including the Evans Glassroth Teaching Award from our Department of Medicine in 2007. Now, Barry Fox is a graduate of Yale and then Vanderbilt for his medical degree. He came to do residency here at the University of Wisconsin, and then that was followed by a research fellowship in infectious diseases, and then a clinical fellowship at the University of Maryland, and then CDC hospital epidemiology training as well, before he took his first academic appointment at Ohio State, and then was involved and eventually promoted to the level of associate professor at the University of Illinois College of Medicine. He went on and actually was involved with industry with Bristol Myers Squibb as Director of Infectious Disease Clinical Research, and while he was in Connecticut was affiliated with the University of Connecticut as well as Yale. He came back to Wisconsin in 2000, initially with the Dean Clinic, and then the University of Wisconsin was fortunate to recruit him onto the faculty, where he's currently a clinical professor of medicine as well as director of the Antimicrobial Stewardship Program. He's well published and has likewise received awards, specifically including Best Doctors in America and Top Doctors for Infectious Disease here locally. So we have two very distinguished professors speaking with us today on not to make light of the very important issue of CAUTI. Urine trouble, bacteriuria, and CAUTI may not be what you think. Please join me in welcoming these two, and I think Rob Hoffman, you're speaking first, so join me in welcoming both of them. Thank you.
Well, thanks very much, Rick. For people who know me since I've been here, this talk has sort of been a long time coming. It's been a mini obsession of mine for whatever reason ever since residency. I think people who know me best hope that finally by giving this talk I'll just stop talking about it all the time so they won't have to hear it anymore. So the objectives for my talk today want to learn to differentiate asymptomatic bacteriuria from a urinary tract infection, to understand the evidence supporting withholding antibiotics for asymptomatic bacteriuria, to gain an improved and evidence-based approach to the delirious elderly patient with pyuria and bacteriuria, and to gain an understanding of the scope of the problem of overtreatment of asymptomatic bacteriuria. And that really, like I say, has been why I've been so interested in this topic, because it's remarkable how much we get this wrong. I did give a talk similar to this, actually, to the Department of Medicine conference, the regional conference a month ago, and I was looking through all of my comments, and I was pretty happy with them for the most part as I was going through it, until I got towards the bottom, and I thought, well, I guess I appreciate the honesty, but I'll try to be neither arrogant nor curmudgeonly today for you. So let's start off with a case. This is a pretty easy one, to do something very straightforward. It's a 75-year-old female who comes into the emergency room with diabetes mellitus, weakness, shortness of breath, no urinary symptoms, a leukocytosis to 14,000, and is afebrile. The urinalysis shows leukocyte esterase, nitrites, a full field of white blood cells, and bacteria. Very common thing that we see in the emergency room. So what is this? Is this a UTI and you're going to treat it? Is this, you can't really tell because there's these nonspecific symptoms of weakness and malaise. The urine is full of white blood cells, so I'm going to treat it because I'm worried. Or is this asymptomatic bacteriuria and you sort of remember vaguely from medical school that you were told you weren't supposed to treat that, so you're not going to give antibiotics? So this is a very straightforward case in my mind, although people often treat this case with antibiotics, as often as not, and I'll get to some of that data later. But it's a completely clear-cut case if you look at the literature. There's no urinary symptoms, the nonspecific malaise, the fatigue. That's not a urinary tract infection. And the urinalysis is not an entirely uncommon finding, and I'll get to that in a little bit. So I want to start off with some simple definitions so that we're all on the same page with what we're talking about. I'm going to go through what asymptomatic bacteriuria is, what a lower urinary tract infection is, and an upper urinary tract infection. You all pretty much know this, so I'm going to go through it pretty quickly, but make sure we're all talking about the same thing. So asymptomatic bacteriuria, no symptoms. And again, what we're talking about is no genitourinary symptoms. It's not the absence of malaise or nonspecific findings. Asymptomatic bacteriuria is the absence of genitourinary symptoms. And just for definitional and research purposes, you need to have 10 to the 5th colony forming units of bacteria on 2 separate urinalyses. And that's, again, important for the definitions and for the studies that I'll go through in just a little bit. Lower urinary tract infection, again, symptoms, genitourinary symptoms. We all know what these are: hematuria, dysuria, frequency, urgency. I do want to point out that people do get confused about the colony counts that are necessary for a urinary tract infection. In patients who are symptomatic, it's been shown that as low as 10 to the 2nd CFU is sufficient to diagnose a urinary tract infection. Mostly with gram-negatives, you have to be a little more cautious with the colony counts for gram-positives. But again, nonspecific symptoms really don't count here. So an upper urinary tract infection, again, you're talking about symptoms. The presence of fever, CVA, pain and tenderness, nausea, vomiting is common. I do want to emphasize caution because they may or may not have lower urinary tract infection findings. So that you can't necessarily differentiate. The same colony count as a lower urinary tract infection. The symptoms are a little less specific, but again, something attributable to the genitourinary tract is part of the definition and is required for the definition and is used again in the studies that I'm going to go through in just a moment. So this is an important point that we learn this and we think we understand this well, but does the UA differentiate asymptomatic bacteriuria from the UTI? And the reason I bring this up is I am constantly hearing people say, well, they've got nitrites and leukocyte esterase, so that's a UTI, not just bacteria. Well, they've got pyuria, so that's a UTI. So do these help differentiate whether this is an infection or just asymptomatic bacteriuria? So first, about leukocyte esterase, I don't even look at that. I almost think it should be taken off of an inpatient urinalysis because it's just a surrogate marker for pyuria. And I've got microscopy. So why do I look at leukocyte esterase? So I take that off. Doesn't add anything to the decision making. Nitrite's the same thing. It's a surrogate marker for bacteriuria. Doesn't add any additional information. I've got cultures. I've got microscopy. Doesn't add anything. And then pyuria, again, this is our diagnostic test. Pyuria is clearly a marker for bacteriuria, but it doesn't tell you, again, whether this is an infection and you should be giving antibiotics or is just this asymptomatic bacteriuria. This just tells you there's bacteriuria. Pyuria doesn't change the calculus one bit either. So now let's go through kind of what we think we know. So we've all sort of learned this, that normal urine is sterile. And I think this is one of the biggest things that confuses people and causes this incredible overtreatment of this condition is people look at a urine and they see that there's pyuria and bacteria in it, and they think that's a clearly abnormal finding. They've got to do something about it. They need to give antibiotics because it's something they can't explain, and they're worried about it. It's not something that we're supposed to have. So here is a table of the prevalence of asymptomatic bacteriuria in selected populations. And I'm going to go through a few of these to hopefully convince you that urine is not always sterile. It's not always an abnormal finding. If you look at the top, healthy premenopausal women, up to 5% at any given time have asymptomatic bacteriuria. Not super common, but also not unheard of. Look at diabetic patients. How many of our patients are in this increasing age of obesity are diabetic? Up to 20% of all diabetic women at any given time have asymptomatic bacteriuria. Reasonably common, not an unexpected finding, not something that you need to explain away, and not something that tells you that the patient has an infection. Diabetic men, up to 11%. Elderly people in the community, 16% of women, up to 19% of men. Again, a reasonably common finding. Look at these numbers from long-term care facilities. Up to 50% of people in long-term care facilities at any time have bacteriuria. So when you order your urine, you get a positive culture, and you think that explains some nonspecific symptoms. Well, this is an expected finding. This isn't a surprise. This is a normal finding, essentially, in elderly patients in long-term care facility. Dr. Fox is going to get into the catheter-associated urinary tract infection shortly. But look at that number at the bottom. Patients with indwelling catheter use long-term, approximately 100% of the time they're going to have bacteriuria and they're going to have pyuria. And of course, like I said before, probably leukocyte esterase and nitrites. This is a normal, totally expected finding. So if you remember nothing else from today, I really want to emphasize this point, that next time you see a urine that has bacteria in it and pyuria, don't necessarily think about it like a blood culture, that it's an abnormal finding. It's something that in our patient population, who do we see? Elderly diabetic patients who are institutionalized, who have catheters in long term. These people, it's really not something that's unexpected, nothing you need to explain away. So just really quickly, of course, there are conditions that we treat for when we do treat asymptomatic bacteriuria. And I just want to quickly make sure you understand why we treat these and why we don't treat in other situations. And this is one of those few places in the infectious disease world where there's actually phenomenal evidence. So we treat pregnant women with asymptomatic bacteriuria. Why? Because the relative risk of developing pyelonephritis is 0.25 if we treat versus if we don't treat. We're helping our patients, a clear evidence-based practice. Those of you who work in clinic know that you screen pregnant women for asymptomatic bacteriuria and you always treat it. Good evidence. Another situation is before urologic surgeries. We always treat and screen and treat for asymptomatic bacteriuria. Again, why? We have really good evidence for this. Up to 60% of patients with asymptomatic bacteriuria will develop bacteremia if they have bladder manipulation. 60%. And we have randomized controlled trial evidence that if we treat this, we can decrease the incidence of bacteremia. Again, solid evidence. A little bit more of a gray zone. What about after removal of a urinary catheter? What we do know is that there's a higher incidence of developing a symptomatic UTI if someone has not cleared their urine within 72 hours of a catheter being removed. There's a higher incidence of developing a symptomatic urinary tract infection if we don't treat than if we do treat. So you should probably treat if they haven't cleared their urine. And a very relatively recent meta-analysis of studies where they gave antibiotics prophylactically after removal of a catheter showed that there is a significant difference in developing a symptomatic UTI if you treated or didn't treat. The number needed to treat in this meta-analysis was 17 by giving prophylactic antibiotics after removal of the catheter to prevent a symptomatic UTI. So it's certainly food for thought. There's no real clear consensus here, but it's something I certainly wanted you to be aware of. And then finally, the immunocompromised patients. All bets are off with this patient population. We don't really have studies. You kind of have to make your own decision based on how immunocompromised somebody is and how sick they appear, how frail they are. There's really not, the ID Society of America doesn't have a strong, doesn't take a stance on this. So that's really it. Those are the patients that we treat for asymptomatic bacteria. Nobody else gets treatment. And I'm really going to try hard to convince you why this is so important. I'm going to go through some of the literature that shows this and try and convince you that this is actually a very important subject to think through much more thoroughly. So first off, I'm going to go through some of these individual studies in a little bit, but a very recent, just this year, a meta-analysis of studies of antibiotics versus placebo for asymptomatic bacteriuria. They looked at 9 studies. These were ambulatory, institutional, and inpatient. of randomizing people to placebo or antibiotics for asymptomatic bacteriuria. And there was no difference in the development of a symptomatic UTI, complications, or death. There was absolutely no benefit in this large meta-analysis. But the relative risk of an adverse event was 3.77 if you received treatment versus you didn't. Clearly no benefit, clearly some harm. What about diabetics? Until 2000 or so, we used to treat diabetics for asymptomatic bacteriuria until we got really good evidence that's consistent. This is a New England Journal of Medicine study from 2002. They randomized 50 diabetics with asymptomatic bacteriuria to placebo, and they randomized 55 to treatment. At 4 weeks, there was definitely a decrease in the bacteriuria in the treated group. So we had decreased the bacteriuria from 78% to 20%. But long term, there was no difference in a symptomatic UTI, pyelonephritis, or hospitalization. And 18% of the treated patients versus 6% of the untreated patients had a medication adverse event. Again, causing harm without any benefit. What about institutionalized patients? So this is near and dear to our hearts, whether we're an inpatient, outpatient doctor who takes care of these patients in their institutions, or we see them in the ER when they come into the hospital. 1983 study showed that patients with asymptomatic bacteriuria who were randomized to antibiotic or placebo, there was no difference in GU morbidity, no UTI deaths at 1 year in either group, but there were side effects in 40% of the treatment group, including rashes, candida, diarrhea, and swollen mouth. Again, we're causing harm to people without any benefit. Again, institutionalized patients, a 9-year observational study where they obtained a urinalysis every 6 months for 9 years on women. These are ambulatory women, so they were more in assisted living, but in institutions. And they just screened them randomly every 6 months, and they showed that there was no difference in mortality between the patients who had asymptomatic bacteriuria and those that didn't. For the final 5 years of the study, they randomized the patients with asymptomatic bacteriuria to antibiotics versus placebo, and they showed that there was no difference in mortality whether they treated this or not. This is an interesting subject that comes up quite a bit, especially for anybody who does inpatient consultative medicine. The orthopedic surgeons like to screen for bacteriuria and treat it, the concept being that bacteremia in these patients when they're putting in hardware is devastating, so we're not going to take any risks. We better treat this and get rid of the bacteriuria. So just last year, a prospective cohort study was done. 2,500 patients with hip and knee arthroplasty were screened for asymptomatic bacteriuria. They found a rate of 12% in this patient population had asymptomatic bacteriuria. Now, I should tell you that this is not a randomized trial, so that's certainly a caveat, but they gave the decision to whether to treat or not to the individual provider, and about 50% got treated. So that shows you sort of the clinical practice. In this population, about half the time, the clinicians thought they should treat this. Overall, 4.3% of the asymptomatic bacteriuria group got a joint infection versus 1.4% who did not have asymptomatic bacteriuria. So clearly, it's a marker that you are more likely to become infected. But there was no difference in the infection risk whether you treated the asymptomatic bacteria or not. And this is what's most interesting to me. There was no correlation between the bacteria that they found in the urine and the bacteria that eventually infected the joint, suggesting that that's not cause and effect. Asymptomatic bacteriuria is simply a marker that you're more likely to develop a joint infection. So right now, the ID Society of America's guidelines don't really take a stance on whether we should be treating this. They're revising them. I sort of suspect with this and some other studies they're going to recommend against it, and I think we're moving more towards that, towards not screening and not treating in this patient population. So this is one of my favorite studies. This is a group of high-risk premenopausal women, average age of about 38, with recurrent UTIs in an STD clinic. So these are recurrent UTIs, high-risk behaviors. They took 673 patients with recurrent UTI and they screened them for asymptomatic bacteriuria, and they randomized them to antibiotics or placebo to see if they could prevent future incidents of symptomatic UTI. At 12 months, 13% of the untreated group versus 40% of the treated group got a symptomatic UTI, number needed to harm of 3. So in this group, giving antibiotics to an asymptomatic patient makes them more likely to get a symptomatic infection. I find this fascinating. There's not a lot of other supportive literature, so I'm not trying to make too strong a point with this, but the concept from this, and there's some other data that supports this idea, is that being colonized by a non-virulent form of, let's say, E. coli, may be protective against becoming colonized and infected with a virulent form of E. coli. So in this patient population, it actually suggests that the asymptomatic bacteria is protective. And lucky for me, just last month, published online by the same authors, this is just last month, they published the results of a 3-year follow-up of this study, and they showed that this difference persists over time. The untreated group had a 37% risk of developing symptomatic UTI. The treated group had almost 70% risk of developing a UTI. So again, we've caused harm. The other thing they did is so in this 3-year follow-up study, what they did is they only got urinalyses and cultures from these women who became symptomatic, and they looked at the E. coli, they looked for all of the bacteria that they cultured, they looked at the antibiotic resistance patterns. I'm just going to show you the results for E. coli, but it was consistent with the other organisms that they cultured. You can see here's the percentage of resistance to these antibiotics in the treated group versus the untreated group. So the patients who originally received treatment for the asymptomatic bacteriuria had a 44% resistance rate to ciprofloxacin. The patients who did not get that asymptomatic bacteriuria treated had a 19% resistance rate to ciprofloxacin. Very robust results, very consistent results. So why don't we treat asymptomatic bacteriuria? Not only is it not beneficial, but we're clearly doing harm to our patients. We're doing harm to our community by causing increased antibacterial antibiotic resistance. And we're not doing any benefit. So, don't treat asymptomatic bacteriuria. I hope I've convinced you of this. I hope I've convinced you there's actually harm here. But one last sort of side point that I wanted to get to is the question of what is a symptom. And I went into this a little bit before. What about delirium? Dizziness, fatigue, malaise. Is that a symptomatic UTI? Well, the bottom 3 I can get rid of easily. I think there's complete consensus in the field that no one really would question, no experts in the field would say that, yes, someone who's dizzy and has a positive urinalysis, that you should treat that. Delirium is a little bit more of a challenging issue. I know our geriatricians struggle with it. Let's start off with what we think we know about delirium and urinary tract infections. I'm going to kind of challenge you to think through what you think is absolute truth. So urinary tract infections are a common cause of delirium in older adults. We all sort of learned this somewhere along the way. Is that true? There's really no evidence whatsoever to support that concept. It's sort of something we all start to learn along the way. What about this one? Not treating a delirious adult with bacteriuria leads to bad outcomes. If someone could show me a study of this, I'd like to see it. There's nothing in the literature that really supports this concept. And a lot of experts really don't believe that this is true. And then finally, treating delirium in older adults improves delirium faster than not treating. True or not true? We don't really know, but we sort of have all come to believe this. One of my colleagues the other day told me that she used to work in an emergency room, and when a delirious patient came in, she was desperately hoping that the urinalysis would show bacteriuria and pyuria, because then she had an explanation and didn't have to wonder what else might be causing the delirium. And I think we know now that that's really a false construct, that you cannot attribute it to delirium. So what do we know about delirium and bacteriuria? Well, patients with delirium are more likely to have bacteriuria, probably, although it's not completely clear-cut. And patients with bacteriuria are more likely to be delirious. In one study, 38% of hospitalized patients with bacteriuria were delirious versus 8% without bacteriuria. So it correlates. The question is there a cause and effect relationship? And I think most experts in the field believe in general that there's not. Delirious patients are more volume depleted. There's one study out there that shows just giving IV fluids to inpatients with bacteriuria decreases the bacteriuria rate. They're more incontinent. They have more comorbid conditions, more urinary retention. So these patients are both more likely to be delirious and more likely to develop asymptomatic bacteriuria. So what are we kind of stuck with? Because there's not terrific data. So I'm just going to kind of close with a couple of consensus recommendations for treating UTIs in institutionalized patients. These are the patients that are more likely to become delirious, the ones we see in the emergency room with delirium and a dirty urinalysis. This is the McGeer criteria. It's one set of consensus recommendations. And this group of experts says you need to have either dysuria or fever and leukocytosis plus GU symptoms, or no fever and leukocytosis plus 2 GU symptoms. In the absence of a catheter, which Dr. Fox will get to in just a minute, delirium or nonspecific constitutive findings are not in their definition. They're not discussed. They're not part of your consideration. This is just one more consensus recommendation, the minimal criteria to treat bacteriuria in an institutionalized patient, which again I sort of think is similar to my delirious patient in the ER. This group of experts said acute dysuria or fever plus genitourinary symptoms. Delirium doesn't count without a catheter also in this other set of consensus recommendations. Doesn't play a role unless you have a catheter. I want to emphasize that. So finally, again, I hope I've convinced you that this is important. I hope I've convinced you that giving antibiotics to these patients has the potential to cause lots of harm. But what is actually happening? And this is why I feel so passionate about this subject. I'm just going to go through a few studies really quickly that show you what's happening out in practice. One study of a community teaching hospital, 47% of inpatient asymptomatic bacteriuria was treated. In a VA medical center, 32% of catheter-associated asymptomatic bacteriuria was treated. The study of an acute care teaching hospital, very much like our own, 48% of asymptomatic bacteriuria and 42% of catheter-associated asymptomatic bacteriuria was treated. In an Ottawa teaching hospital, a prospective study found that 72% of catheter-associated asymptomatic bacteriuria was inappropriately treated. The Canadians get this wrong more than we do. 43% of elderly women discharged from an ER in one study with a UTI had a negative culture. So this is in asymptomatic bacteriuria. They didn't even have bacteriuria. They probably had some nonspecific symptoms, and the ER doc wanted an explanation, so they said, well, it's probably the urine. 41% of nursing home patients not meeting UTI criteria were treated with an 8.5-fold increase in C. difficile risk. This is completely unacceptable. Where else in medicine do we accept this kind of inappropriate treatment? Half the time we're getting this wrong, and I think I've shown you pretty solid evidence that not only is it wasteful, it's actually harmful to our patients. I don't think we're trying to do this wrong. Like I say, what I really think, and I don't know, I'd like to hear what other people have thought, I think a lot of it has to do with people think that a bacteriuria is sort of like a bacteremia, something I need to explain and I need to treat. So, in conclusion, pyuria and bacteria are frequently a normal finding. And don't treat asymptomatic bacteriuria except in pregnant women before bladder manipulation and possibly the immunocompromised. 30 to 70% of inpatient and institutional asymptomatic bacteriuria is inappropriately treated. And finally, please be judicious in the use of antibiotics in the delirious elderly patient with bacteriuria. So thank you for your time, and Dr. Fox is now going to educate us about the very important subject of catheter-associated urinary tract infections. Dr. Fox?
Well, thanks, Rob. We're going to have a good complement to the non-catheter patients, to the catheter patients here. And I want to thank Lindsay Voss for her contribution to our clever title here about urine trouble here. We can't take full credit for that. So my objectives today are threefold here. I'm looking to make you understand that their need to place a Foley catheter should only be if absolutely necessary, and if it's placed, to remove a catheter as soon as possible. I also want you to understand that fever in the hospital including the intensive care unit, is usually not due to a, quote, urinary tract infection, and cultures should not routinely be obtained. We'll go into this in a bit. And finally, to recognize that 30% of antibiotic overuse in the hospital is due to treatment for presumptive urinary tract infections. And of course, that this unnecessary antibiotic use leads to several undesirable consequences. I'm going to start off talking about catheter infections by defining what a catheter urinary tract infection is. And we're going to henceforth call this CAUTI, so we don't have to say the words out here. All right, so we really have two definitions. We have a government definition of what a CAUTI is, predominantly by Medicare. And then we have a more practical definition of a CAUTI. So what is the government definition, and why is this important to us? The government definition involves three components. You have a catheter. You can have a whole variety of nonspecific symptoms, and we'll talk more about symptoms in catheterized patients in a minute. But importantly, this symptom could just include fever, according to Medicare. And then you have a positive urine culture. Well, that doesn't make a whole lot of sense. So that means a positive urine culture in a patient with a fever equals a Medicare CAUTI, even if the fever is found to be due to another cause. Doesn't quite logically fit the spot here. Now, our more meaningful definition of a CAUTI is really a positive catheter urine culture and, of course, a clinical illness attributable to the genitourinary system, and where other sources of illness or infection have been excluded. Much more practical definition. Now, before I move forward here, I want everyone to understand some of the historical perspective on CAUTI research, because we have a very strong tradition of CAUTI research here at the University of Wisconsin, a lot of which is by Dr. Maki. I'm going to briefly go into three studies by Dr. Maki, one that deals with quantitative levels of bacteria, one that deals with pyuria, and the other one which deals with symptoms in catheterized patients. Now, the first of Dr. Maki's studies was published in the New England Journal of Medicine in 1984, and it had two major conclusions. He taught us that the risk of bacterial colonization of the urine increases by 7 to 8% per day of catheterization. And he had a medical student running around every single day culturing everyone's Foley catheters. So if you do the math, at day 14, 100% of individuals are going to have a positive urine culture. The second thing that he told us, that once the catheters are colonized with low-level numbers of bacteria, say 10 to the second or 10 to the third, that within 96 hours, this progresses to a quantitative count of 10 to the fifth. So these numbers that you get, you might get a urine culture here that might say 10 to the second, 10 to the third, they are potentially clinically meaningful because, again, 48, 72 hours later, they will have higher numbers. Once colonized, the numbers are just going to increase. The second major study that was published in the Archives of Internal Medicine in 2000, and this dealt with pyuria. And he taught us three important lessons. First, there was an association between pyuria and gram-negative bacteria. But the association was much weaker when we dealt with enterococci or yeast. Perhaps most importantly, the absence of pyuria is helpful primarily for its negative predictive value. And thirdly, he concluded that pyuria should not be used as a sole criteria to obtain a urine culture. All right, what about his third study, which was also published in the same journal, and this dealt with symptomatology for catheterized patients. Now, Rob emphasized that patients without catheters really had to have symptoms for the genitourinary tract, frequency and dysuria. Well, Dr. Maki's study showed that really 96% of patients that had indwelling catheters did not have these symptoms, not unexpectedly because they had a catheter in their bladder. So, but these were some of the same symptoms Medicare used to define CAUTI here. So this is, it's really hard to make a Medicare definition when they ask for symptoms, but patients don't have symptoms. And therefore, fever stands out when it comes to the Medicare criteria as the predominant symptom for CAUTI. All right, so I have a few slides here that say, what's all the fuss about CAUTI at UW Hospital? And this is very, very important to us in the next few slides here. We're going to talk about the added cost of hospitalization, but more importantly to the hospital, the Medicare reimbursement policy and penalty for CAUTIs. In 2007, the federal government issued a federal register and said that hospitals would no longer be reimbursed for hospital-acquired conditions, and some of those related to infections, such as bloodstream infections, but in particular, they singled out CAUTI as one that they were not going to reimburse hospitals for. Now, the attributable cost of a CAUTI is actually not very much. I'll show you in a second. It's about $1,000. But they went further than that. There was one exception, too, about these CAUTIs here. If there was a condition that was present on admission, so people had positive cultures at the time of admission, then that didn't count against the hospital. So let's look at the financial impact potentially at UW Hospital. Big dollars here. All right, the attributable cost I mentioned is about $1,000. Okay, we can probably live without that if someone really develops a CAUTI. More importantly, Medicare has two scorecard systems that deal with what's called value-based purchasing, and yet another scorecard system that deals with hospital-acquired conditions. And in this scorecard, in this formula, which I'm not trying to show you here today, but in this formula, a CAUTI counts as much as a bloodstream infection. Doesn't make any sense, but the number counts just as much as a bloodstream infection. So in this formula, there's a lot of dollars that are at risk. How much? Well, somewhere between 1 to 2% of all the DRG reimbursement for Medicare, which translates to somewhere between $2 to $4 million. So our performance right now with respect to CAUTI will be reflected on payments for Medicare about 2 years from now. And so we have somewhere between $2 to $4 million at risk regarding our performance on CAUTIs right now. Well, what happened this year? Our performance from 2 years ago was greater than 20% above the norms for Medicare, okay, just outside what they considered their boundaries. And because 2 years ago these CAUTI numbers were much higher, the hospital lost over $1 million in reimbursement from Medicare. So a big concern. So what's the rub here? We have too many catheters. We have too many days of catheterization. We have too many urine cultures for fever as part of pan cultures. And these subsequently get counted as CAUTIs. And of course, as I'll show you, we have too many antibiotics, likely for insignificant positive results. All right, I'm going to step back just a teeny bit here and go back to the basics of inserting a catheter and removing the catheter here, just with these next few slides. Inserting catheters, there's been estimates in the literature, and approximately 15% of adult inpatients will have a urinary catheter, but more than half of those catheters probably do not have an appropriate indication. And Dr. Hoffman wanted me to point out that the impulse and need for monitoring urine output should not necessarily be a reason to place a Foley catheter. What have we done here at UW? Well, in HealthLink, we actually have an order for placing a urinary catheter, and you have to actually put the reason in here for why you're putting the Foley catheter in. Perhaps more importantly, at the bottom here, there's a urinary catheter removal protocol that's nurse-generated, and that's right on the antibiotic order form. On the Foley catheter order form to begin with here. So this nursing administrative removal of catheter has shown the potential to reduce CAUTI by as much as 50%. And this is a little bit hard to read here, but we do have this sophisticated algorithm that does get catheters out. And I'll show you at the end of my presentation what that's meant regarding the number of catheter days at UW Hospital over the last few years. All right, so here's the big question here. If a urine catheter is in, what are appropriate indications for ordering a urine culture? Well, ordering urine cultures. What about altered mental status? Well, Dr. Hoffman has already addressed that issue, and we can take questions later. Probably not for altered mental status. Let's focus a little bit on fever. Is fever enough? Do we have to pan culture everyone? Well, our 2009 Infectious Disease Society of America guidelines said we should actually be looking for alternative sources of fever before attributing any fever to the urinary tract. Well, that sounds okay for the floor patient. What about patients in the intensive care unit where the stakes are higher? Well, we're turning to Dr. Maki again for some more advice about this because he was the author of the critical care guidelines for new fever in critically ill patients that was published in 2009. And what did he say? Well, he basically reiterated the same three lessons that he told you in the three papers that I reviewed earlier. So not much different in the intensive care unit related to fevers. Now, this was published in 2009, but do I have any more supportive literature regarding the intensive care unit and fever and catheter-related infections? So this study is from the Mayo Clinic. It's actually in press right now. It's not fully released. It found that most patients with a CAUTI, fever could be attributable to another source, be it pneumonia, bloodstream infections, or even non-infectious causes such as intracranial bleed. Even in patients with no other identified causes for fever, and they knew there were positive urine cultures, great for them, they ignored the urine culture results 34% of the time. In years past, it might have been 15%, but I think we're coming to realize the significance of this and the not need to treat. So their findings, again, in the ICU suggested that urine cultures in ICU patients rarely help clinicians manage the overall patient care. Again, hot off the press. All right, so back to our slide. What's all the fuss about CAUTI at UW? Let's look at infectious complications, and let's look at one of the questions, how frequently does a catheter urinary tract infection result in a bacteremia? Well, the answer is not frequently. How do we know that? Well, let's go back to Dr. Maki's original 2000 study. In his study, there were 0.4% of cases that CAUTI resulted in a bloodstream infection. In a later publication in Infection Control and Hospital Epidemiology in 2013, the number was 0.7%, again, mostly dealing with floor patients. Now you might be wondering, well, what about the ICU? It's got to be higher than that. And it is. And how do we know? Well, the recent study that I just alluded to from the Mayo Clinic, they had a 6% number with the bloodstream and urinary match. So not unexpectedly in the intensive care unit, the number is going to be higher. But think about it, it's still 94% don't end up with bacteremia with the positive urine culture. All right, the last part about the fuss here. What about antibiotic use, antibiotic-resistant organisms, and our stewardship interventions to try to reduce ordering of catheters and reduce antibiotic ordering? Let's look at the national perspective very briefly here. In 2014, the Center for Disease Control published this Morbidity and Mortality Weekly that was titled Improving Antibiotic Use Among Hospitalized Patients. Okay, pretty generic. But what they found was that if antibiotics were used more appropriately for asymptomatic bacteriuria, including CAUTI, there would be 30% reduction in antibiotic use. And their statisticians went on to extrapolate that this would translate into about 25% reduction in the incidence of Clostridium difficile-related infections. Well, what about antibiotic stewardship interventions to reduce inappropriate ordering and prescribing, mainly educational efforts such as us being here today? I'm going to focus on one study, and this study was from the Houston Veterans Hospital system. I have 2 slides on this. Basically, the stewardship program educated all providers regarding when they should get urine cultures and when they should possibly treat urine cultures. And it's a relatively well-done study with several centers randomized to not receiving the education and others receiving the education. Here's their baseline numbers, and there's no, in the non-intervention group, there's really no difference either in the intervention or maintenance phase, but in their educational efforts for those educated, there's a dramatic reduction in the number of ordering of urine cultures, and this was maintained in the later time windows here. And similarly, the antibiotic use in the same time windows also fell significantly, and it also persisted in the maintenance period, indicating that the education, at least during the length of time of their follow-up of several 6 months or so, had persisted. And my hope is that this grand rounds will also serve a similar purpose. Okay. What are we doing here at UW to try to reduce the ordering of urine cultures? Well, one thing that we've trialed and piloted is in the emergency department, we have uncoupled this terrible order that says urine analysis and reflex urine culture if there's greater than 5 white cells. Well, what are the results? They're actually encouraging. I just got this full data last evening here. So the intervention started in January of 2015, and that's in blue here. And this is the 4-month time window beforehand. On the average in the emergency department, there were about 300 urine cultures ordered in the pre-interval here. And shortly after the education, the numbers have held true at about a 30% reduction over the past 4 or 5 months. And what's also interesting is that individuals are probably ordering urine analysis, and then they're only ordering a urine culture after they've looked at the urine analysis, because you can see the number of add-on requests for urine cultures has been increasing over time, but they're just not ordering a urine culture from the get-go here. So this is potentially good. We're thinking about moving this out house-wide here, or changing the numbers of white cells if they have the reflex culture to a higher number here, because 5 is pretty arbitrary. All right, one more thing that we're trying to do here at UW here, we tried a pilot study in EPIC to try to, a lot of our CAUTI infections that count against us in Medicare happen in the TLC, and they happen in the neurosurgical intensive care unit. So what we tried to do was have an order in HealthLink that educated individuals for the appropriate indications for ordering urine cultures and forced them to put in an order for what they were actually trying to treat. Now, unfortunately, this didn't work out as well as we expect. This is a little bit hard to see, but I'll try and give you the difference. We just got the results this week. So in the neurosurgical ICU, there was no difference when this when this order form for a Foley catheter was instituted here. Absolutely no difference, no change in their pattern of behavior here. In the TLC, there was the number of cultures was down. There was a slight drop in the number of, or the rate of urine cultures that were ordered. Again, probably not statistically significant. And if we look at the critical care service as the service in the ICU, again, there was a small drop between 0.86 and 0.71. Again, not statistically significant. But what did we actually find out? There was actually a mistake that we made. We did not have a hard stop on this order. So people could blow through this and still order their urine culture. And we were very disappointed that we didn't have a hard stop on this. So we're going to redo this here. Our hope is to go house-wide on this very soon. Okay, in my concluding slides, I want to show you here what really has happened at UW Hospital over the past 5 years. And the information in general is very good. Let's look at the blue line here. The blue line represents the number of device days, all right? How many days per 100 patient days here of catheter utilization? And you can see since 2011, through multiple education efforts in our automated protocols, the number is down dramatically. The red numbers represent the actual CAUTIs that count against us for Medicare here. And the rates have gone down, 4.2, 3.5, 3.1. 3.1 was the same. But again, we've made much more intensive efforts in the past 9 months or so, and these numbers are starting to dramatically fall. If we continue our current trends and behaviors, this would mean over 100 fewer urinary tract infections since 2009. This would put us into the compliance range with Medicare. This would lead us not to have these additional multi-million-dollar penalties for the institution. But it's all up to us. Okay, we're all part of this. So my conclusions are, we want you to leave the catheter out if it's not needed. We want you to take them out as soon as feasible. Don't reflexively order a urine culture for fever. At least look at the urine analysis first. Bacteriuria is common with catheters, but is uncommonly the source of fever, including in the ICU, and it's rarely the cause of bacteremias. And finally, as you might expect from me, not using antibiotics is usually good stewardship. Now, I have to conclude with this slide, which has been given to me by Dr. Maki years ago and shown before at Grand Rounds here. If all else fails and the residents need, this is what has to happen. All right, so I guess it's time for us to open the floor to questions for Rob and myself.
Dr. Fox and Dr. Hoffman, I want to thank you just for an outstanding presentation. The tag team worked beautifully. This is such an important issue. The CAUTI, it's not just about saving money. It's about saving lives and being better stewards of our antibiotics. So this couldn't be more timely and important. I'll ask you two to call on the audience. We've got 5 minutes for questions. Please repeat the question for the recording, and we'll close at the hour. We'll open this up to questions.
Bennett?
That was a wonderful presentation. I see on the order set that we can still put a Foley in to monitor urine output. Are we ready to get rid of that indication completely, or at least narrow it severely from our organization?
So the question is are we ready to remove as an indication for putting in a Foley catheter the monitoring of urine output? I think we're getting there. So institutionally, there's been a strong effort to allow us to monitor urine output in our incontinent patients without a Foley catheter. People can wear incontinence pads, which can hold, I believe, up to 10 liters of urine or some absurd amount of urine. And then those get weighed, and you can monitor urine output. The Hospital of Society Medicine has as one of their strong recommendations of what not to do is not using a catheter for monitoring urine output, because you should be able to use daily weights for that. To be honest with you, in real practice, it's still somewhat of a challenge, so I think this is something that we need to continue to work with very carefully with nursing to make sure that we can get these adequate urine outputs. They've had a lot of success in an ICU pilot. So I think we're getting there, but maybe aren't quite there yet with completely removing it.
The question is, what is our criteria for immunocompromised patients? Are we talking about in terms of treatment of asymptomatic bacteriuria or treatment of positive catheter urines? Ian? What's that, both? All the above? Well, the immunocompromised question has always been one that's even more controversial and much more in a state of flux. I can answer maybe a little bit more to the issue of like renal transplant recipients. So in the past, every positive urine culture for renal transplant recipients used to be treated with antibiotics. The literature and state-of-the-art has evolved so that they are only treated if it's in the first 3 months after transplantation, and then after that, it's based on really are there really symptoms that are present and associated with a positive culture. So they allow for asymptomatic bacteriuria. In a neutropenic patient, I think we'd have to individualize the case. Ian, first of all, I want to be sure that the culture was positive. If it was a positive culture that was collected properly, because sometimes I get called for VRE in the urine on an immunocompromised patient and they give a better sample and it's not there. But I think they just have to be individualized. I don't think there's a really known standard for the neutropenia group. Yes? The question is there a role for, you really want to, you mean a serum procalcitonin for distinguishing?
I did come across some urinary procalcitonin studies as well, but I still very officially dispute them. I haven't been able to read them in detail, but
Okay.
I think there are some assays available which can detect urinary procalcitonin.
So,
I'm not sure if they're able to distinguish between.
So the question was whether an actual urinary procalcitonin level would help distinguish between a true infection or not. I guess I didn't investigate that literature. I'm sorry, Rob, do you know anything about it?
I don't know the answer to that, no. But I certainly don't think that there's enough out there that we're starting to do it, but it might be something for the future.
Another question? Yes.
Why we really have to order the UA if we really not going to look at the results? I mean, what's the point if the patient has no symptoms of UTI and we still do the UA as an emergency room in the hospital since it's going with asymptomatic bacteria even if it's mild?
So the question is, why are we ordering a urinalysis if we're not going to care about what the results are, even if it's positive? And that's an outstanding statement. I couldn't agree more. It's a real problem. So as I've been emphasizing, people, residents will never get yelled at for over-treating a positive urine culture, but they're nervous they're going to get in trouble if they don't give antibiotics for the positive urine culture. And in the emergency room, it's almost like an admission lab at this point. The urinalysis is ordered, before the doctor even sees the patient often. And I think if we can decrease the ordering urinalyses, hopefully by asking for indications, that we can really have an impact on that. But thank you, that's a very important point. We should not be getting the UAs if we don't want to know what the results are.
On that point, we're going to need to close. I want to thank the audience for being here. We have a great lineup for Grand Rounds this year. Thanks to Lindsay Voss, one of our chief residents. Please encourage your colleagues and friends to join us here next week. And in closing, I just want to thank Drs. Hoffman and Fox for just an outstanding Grand Rounds.